Welcome to the lecture on bedside pelvic ultrasound. My name is Zevallos, and today I'm going to introduce you to the point-of-care pelvic ultrasound, truly focusing on the first trimester sonography. For this lecture, I have no conflicts of interest and nothing to disclose. So for the learning objectives, by the end of this lecture, I want you to be able to interpret normal female pelvic anatomy and early pregnancy structures using the ultrasound, be familiar with the indications for bedside pelvic ultrasound, be able to assess for intrauterine pregnancy, and understand the sonographic findings that definitively rule in an intrauterine pregnancy, and understand the high-risk sonographic findings that should increase your concern for an ectopic pregnancy. Now, before we get into the nuts and bolts of the point-of-care pelvic examination, there are a couple things I want to lay out early on. First of all, I feel that out of all of the point-of-care examinations you will be exposed to, this is the most difficult to learn initially. There are many reasons why I say this. The exam itself is one of the only applications in the point-of-care ultrasound world that is invasive. We use a probe which is largely unfamiliar unless you have been schooled in obstetrics and gynecological exams in the past. The eye-to-hand coordination with the probe to what you see on the screen is very different than when using the other ultrasound probes, and it's often performed on patients who are in a very intimate or stressful stage in their life, making the stakes of your findings much more significant than other examinations. With that said, the point-of-care pelvic ultrasound is one of the most commonly used examinations, and as we'll talk about, with proper guidance and practice, it can become an invaluable tool in your armamentarium. So let's get started. Before you learn something new, you always want to know, is this really important? Does it really matter? And is it going to make me do anything different than what I already do? So what is the benefit of learning to use the point-of-care pelvic ultrasound? Well, let's see. Approximately 1 to 2% of all pregnancies in the United States are ectopic. However, they account for approximately 4% of pregnancy-related deaths. In 1984, the mortality rate of an ectopic pregnancy was approximately 1.15 deaths per 100,000 live births. According to the CDC, with advancement in technology, the mortality rate has declined to less than 0.5 deaths per 100,000 as of 2010. Now, how does point-of-care pelvic ultrasound play into this decline in mortality? Looking at the literature, in 2006, Mateer and company looked directly at outcome measures with the introduction of a point-of-care pelvic ultrasound protocol. In this study, the use of bedside transvaginal ultrasound improved early detection and decreased overall morbidity in patients with ectopic pregnancies. In patients who were clinically screened and did not receive an ultrasound, 20% of those patients with an ectopic were sent home, half of which eventually ruptured prior to being found. This was compared to the ultrasound protocol-driven group, where only 2.5% of patients with an ectopic pregnancy were sent home. Moving on, not only does point-of-care pelvic ultrasound decrease mortality, but she and company found through their research that it also dramatically decreases patient wait times. According to their article, patient wait time went from 3 hours to 1 hour when doing the identical workup, with the only difference being whether a traditional complete pelvic ultrasound was performed or a point-of-care pelvic ultrasound was performed at bedside. Now, similar to the other point-of-care examinations, you want to view all structures in 2 planes, scanning slowly to identify all structures. Look for any abnormalities within or outside of the uterus, paying special attention to the ovaries and the adnexa. There are 2 methods of ultrasound used in the pelvic examination, the transabdominal and the transvaginal approach. The transabdominal exam is similar to the other abdominal ultrasound exams in that it is non-invasive but gives less resolution when compared to the transvaginal approach. The transvaginal approach can detect OB findings up to a week earlier on average and allow for detailed evaluation of the adnexa and ovaries. The clinical indications for an OB ultrasound include any first trimester pregnancy presenting with abdominal pain, vaginal bleeding, syncope, or shock. Now, I understand these symptoms can be vague, but personally, if you are a female walking into the emergency room on one of my shifts and you've never had a prior ultrasound confirming an intrauterine pregnancy and you're pregnant, you will very likely be receiving an ultrasound from me. The clinical applications for an obstetric ultrasound are numerous. The primary application is to rule in or identify an intrauterine pregnancy. Depending on the stage of development, it may not always be possible to definitively visualize an IUP, or pregnancy. In order to call an intrauterine pregnancy definitively, you must visualize the gestational sac along with the yolk sac or the fetal pole. An intrauterine pregnancy is considered live once you visualize a fetal heart rate. Be wary of what appears to be an empty gestational sac sitting within the uterus, as this could be an early normal pregnancy but could just as easily be a pseudo-gestational sac in a patient with an active ectopic pregnancy. The ultrasound can be used to evaluate for free fluid within the abdominal or pelvic cavity. Hypotension in a pregnant female with a positive FAST should always be considered an ectopic pregnancy. The evaluation of the adnexa and ovaries for masses also aid in the risk stratification of patients for a possible ectopic pregnancy. Very similar to most of the point-of-care examination, there are dramatic differences in the goals between the point-of-care examination and the complete or radiology performed pelvic ultrasound. The sole goal of the point-of-care ultrasound is for the evaluation of an intrauterine pregnancy. The identification of an intrauterine pregnancy, for our purposes, essentially rules out an ectopic pregnancy, with the exception of the very rare cases of heterotopic pregnancies. In natural conceptions, it is estimated that heterotopic pregnancies occur 1 in 30,000 pregnancies. This number dramatically increases in women undergoing ovulation induction or an in vitro fertilization. In contrast to the point-of-care examinations, the complete pelvic exam focuses on subtle findings of the uterus and ovaries, is used to evaluate for the expected gestational age of the fetus and to evaluate for complications with pregnancies, including fetal anomalies or placental anomalies. Patient positioning is intuitive. For the transabdominal approach, the patient will take the typical supine position. An important rule is to remember that the full bladder during the transabdominal approach will act as a median for which to allow the sound waves to reach the uterus, improving the overall resolution and visualization of the uterus. For the transvaginal approach, the patient will need to be in the lithotomy position with their legs to the side as far as possible, identical to the position the female takes for a speculum exam. The bladder needs to be completely empty when using the transvaginal approach, otherwise it will cause compression and distortion of nearby structures, making visualization of the uterus and or ovaries difficult and sometimes impossible. The traditional curvilinear or abdominal probe is used for the transabdominal approach, while the higher frequency endocavitary probe is used for the transvaginal approach. Remember, higher frequency yields better resolution and detail. Most ultrasound machines should have a dedicated obstetric setting, which will include important software allowing for the calculation of fetal heart rate, expected gestational age, and other obstetric-specific calculations. For the transvaginal examination, the cavitary probe will be placed intravaginally. When looking at the uterus in long axis, the probe indicator will point anteriorly, as shown in this picture. Turn 90 degrees either clockwise or counterclockwise to evaluate the uterus in cross-section or transverse axis. For the transabdominal examination, the probe is going to be placed suprapubically with the indicator pointing toward the patient's head to obtain the long axis view of the uterus, or toward the patient's right to obtain a cross-sectional view. So here are the critical views that you want to pay special attention to when performing this examination. You always want to start off with the uterus in long axis, as demonstrated here, and you want to early on identify that endometrial stripe, which is right there. Now you can follow this endometrial stripe posteriorly to the cul-de-sac or anteriorly up to the cervix. Turn 90 degrees in order to evaluate the uterus in short axis. Evaluation of the adnexa and visualization of the ovaries is sometimes difficult. The easiest approach I have found is to start off with the uterus in short axis, and then pan off to the side of the uterus, maintaining the short axis, and pan up and down. Once you locate the ovaries, evaluate them as well as the adnexa in both long and short axis. Let's start looking at some real-time examples of normal anatomy and structures while performing the transvaginal ultrasound. As you can see, we start off with the probe indicator facing anteriorly, which gives us the long axis view of the uterus. Once we have the long axis view of the uterus, we want to pan side to side until we visualize that endometrial stripe. From there, we can follow the stripe posteriorly to evaluate the cul-de-sac, or follow it anteriorly in order to evaluate the cervix. We then want to turn 90 degrees, either clockwise or counterclockwise, in order to get the uterus into the cross-sectional orientation. We then want to sweep from top to bottom in order to visualize all of the uterus. Now, once we've seen the uterus in its entirety, we want to pan off to the side of the uterus, looking at the adnexus and the ovaries. And again, once you identify the ovary, you want to look at it in two planes. Now, looking at the transabdominal view, you again want to visualize the uterus in long axis first and identify that endometrial stripe right there. From there, you can follow the stripe either posteriorly or anteriorly to evaluate for the cul-de-sac or the cervix respectively. Lastly, pan side to side and long axis to visualize the entire uterus. Again, you'll want to turn 90 degrees in order to obtain the transverse view of the uterus and pan top to bottom. Okay, let's backtrack a little and take a quick second to make sure that everyone is familiar with the normal female pelvic anatomy. The fundus is the top portion of the uterus furthest away from the cervix. The portion between the fundus and the cervix is the body of the uterus. The endometrial cavity can be seen in the centermost portion of the uterus running long axis within the uterus, eventually joining to the cervical canal. You can see on top is your traditional picture format, and on the bottom is your sonographic equivalent. Learning to evaluate the uterus tends to come fairly easy for most people. It's not till we start indulging into the ovaries that most people start having problems. And it never fails, no matter what the patient's complaint is or the indication for the ultrasound, the ovaries always have some kind of cystic structure. And then the question arises, is it a cyst or is it a follicle or maybe a corpus? Who knows, right? So let's talk about each of these really quick. Remember, the follicle is the most basic unit of the female reproductive cycle, and each follicle contains a single egg. Follicles are periodically initiated to grow and develop. The dominant follicle will grow from microscopic size up to about 20 millimeters, at which point it will burst and release an egg. Now, a follicle is a cystic structure, and the terms are very often used interchangeably. However, nobody can say for sure whether we see a good follicle or some other type of cystic structure just using one ultrasound scan. If you were to repeat the ultrasound 3 days later and saw that that cystic structure had increased in size, then you have a pretty good idea that it's a developing follicle. Now, the corpus luteum is formed from a follicle after ovulation occurs. As you can see on the lower picture, there are multiple cystic follicles with a dominant follicle at the 1 o'clock position. And here are some examples of a corpus luteum. And as you can notice, here you have the traditional thickened wall of the corpus luteum. And if you apply color Doppler, you get this traditional ring of fire appearance, representative of the increased peripheral vascularity. Once again, the primary goal of point-of-care pelvic ultrasound in the setting of the first trimester pregnancy is for the confirmation of an intrauterine pregnancy. Now that you all have a pretty good handle on what normal anatomy looks like, let's move on to talk about more sonographic findings, specifically for the first trimester pregnancy. The gestational sac is the earliest sign of pregnancy on ultrasound and is typically seen at about week 4 or 5. This roughly corresponds to a beta HCG of about 1,000. The gestational sac should be slightly off midline to the endometrial stripe and should be ovoid or spherical in shape. Despite the gestational sac being the first ultrasound finding of pregnancy, identification of a gestational sac cannot be used in ruling out an ectopic pregnancy, nor does it depict a definitive intrauterine pregnancy. One of the problems with sonography in early pregnancy is the inability to clearly determine if the gestational sac is intrauterine or extrauterine in nature. Now, even when the sac is seen within the uterus very early in pregnancy, then the controversy as to whether the sac is a true sac or a pseudo-sac of ectopic pregnancy further adds to complicate matters. Many radiologists and obstetric physicians use the double decidual sign as their first indication that the sac inside the uterus is a true sac and thus a normal developing pregnancy. The double decidual sign develops around 4.5 to 5 weeks of gestation and is characterized by a hyperechoic ring surrounded by another hyperechoic ring. Now these two rings are separated by an anechoic space of fluid. At times, seeing the double decidual sign can be subjective, and because of this we cannot use it as a sign of a definitive intrauterine pregnancy. If clearly seen, then you can say that the patient has a probable intrauterine pregnancy, but again, never call a definitive IUP until you see a yolk sac. And let's talk about the yolk sac. The yolk sac provides early nutrition for the fetus. Sonographically, it appears as a small circular structure, usually seen around week 5 of gestation, and disappears at about week 12 when the placenta begins providing nutrition to the fetus. The yolk sac shouldn't be any larger than 6 millimeters, and when seen within a gestational sac, which is within the uterus, it is the first sign of a definitive intrauterine pregnancy. The fetal pole is a sac of fetal cells which separates from the yolk sac and begins to grow at approximately 1 millimeters per day, beginning around week 6 of pregnancy. It is used by obstetrics for dating purposes during the first trimester of pregnancy. Sonographically, it is seen as a growth adjacent to the yolk sac at about weeks 5 to 6 and also is indicative of an intrauterine pregnancy. Alright, so that covers all the expected intrauterine findings in the first trimester pregnancy. Now let's take a quick look at what a complete examination would look like, starting with the transvaginal approach. So again, here's your uterus, and as you can see within the gestational sac as you're sweeping through, you start to see fetal parts. And if we look carefully when this restarts, you'll see a yolk sac sitting up in this portion of the gestational sac. You can appreciate the double decidual sign with a hyperechoic ring surrounded by another hyperechoic ring. And there's your yolk sac right there. And here's your fetal pole or fetal parts. Now let's take a look and see the transabdominal approach. So here's your uterus right here, and within the uterus you see a gestational sac. And if you look closely as you're panning through it, you'll see on the right hand side of the screen within the gestational sac the yolk sac sitting in that portion right there, and adjacent to the yolk sac you see the fetal pole. The fetal heart rate is one of the earliest indications of a living fetus. Earlier in pregnancy, it will be noticed as a flickering within the fetal pole, first seen when the fetal pole is at least 5 millimeters long. As the heart matures, it takes on the expected 4-chamber appearance, making it easier to visualize. The heart rate varies by fetal age, ranging anywhere from 100 to 180 beats per minute. Any heart rate less than 100 is a predictor of fetal demise. M mode or motion mode takes a standard ultrasound 2D image and plots it against time, allowing for calculation of the fetal heart rate by measuring from one systolic peak to the next. Here's an example of how to obtain the fetal heart rate. As you can see, the M mode line is coming straight down through, and you can see the little flickering of a heartbeat right here. Now let's move on into a few of the more common abnormal uterine findings that you may come across. While we were talking about the gestational sac a few slides ago, I mentioned the term pseudogestational sac, and here's an example of one. When looking for the gestational sac, identification of a pseudogestational sac is the most common reason for a false positive finding. Much like a gestational sac, it is a fluid-filled structure within the uterus. However, unlike a gestational sac, it does not have the double decidual sign, and it usually sits in the middle of the endometrial stripe compared to the off-center location of the gestational sac. Remember that a pseudogestational sac can exist with an ectopic pregnancy. Fibroids are muscular tumors that originate from the myometrium and cause displacement or distortion of the normal uterine anatomy. This becomes important because it also makes identification of normal pregnancy complicated depending on the size of the fibroid mass and the degree of displacement of normal anatomy. Here's an example of a relatively large fibroid found on a pregnant female. Notice how the gestational sac is displaced away from its normal midline position on this still image. And here's an example of what a fibroid would look like on a real-time exam. Here's your uterus, and notice this mass sitting within the uterus that distorts your normal appearance of the uterus. And see how it displaces the gestational sac away from the midline? A molar pregnancy is an abnormal type of pregnancy due to an abnormal fertilization process which has distinct sonographic characteristics. During this type of pregnancy, the chorionic villi rapidly proliferate and swell in clusters resembling grapes, which produces the characteristic vesicular sonographic pattern, also known as a bunch of grapes or a snowstorm appearance. The uterus is significantly larger than would be expected for an early pregnancy, and the beta HCG is significantly elevated. Here's an example of a molar pregnancy found by ultrasound. Notice the classic echogenic mass within the enlarged uterus with numerous small anechoic spaces. These are the hallmark ultrasound findings for a complete molar pregnancy. The most commonly visualized anteverted uterus deflects slightly anterior toward the bladder, which thus far has been true of all of the pictures and videos we have seen. Anywhere between 1 to 3 to 1 to 5 women have a retroverted uterus, where the uterus deflects posteriorly toward the spine. Sonographically, the anatomy appears similar but reversed, with the fundus being on the right side of the screen as seen here, and the cervix being on the left. Depending on the degree of retroversion, this can also lead to a more difficult finding of the uterus initially. So I've already spent some time talking about follicles and the corpus luteum. Remember that follicles are cystic structures, which are usually 2.5 to 3 centimeters in diameter. The other common ovarian finding that you often see is an ovarian cyst. These are typically larger than 3 centimeters and do not grow on a daily basis like a follicle would. Similar to other cystic structures in the body, you can have a simple or a complex cyst. Simple cysts are defined by the smooth wall, anechoic, circular structures with posterior acoustic enhancement, in contrast to a complex cyst which has echolucent or echogenic areas. A complex cyst has to raise your concern for an abscess, hemorrhage, or cancer. So here's an example of a simple cyst. Note how it is anechoic, circular in nature, and has a smooth, thin wall, and it's difficult to see here, but you can appreciate some posterior acoustic enhancement. And here's an example of a complex cyst. Note how it has a thickened wall, and you have this echolucent or echogenic material within the cystic structure. Free fluid within the pelvis can be secondary to many pathologies, most concerning clearly being ectopic pregnancy or trauma, though small amounts of free fluid can be physiological. Fluid most commonly collects in the retrouterine space known as the pouch of Douglas, which lies between the posterior portion of the uterus and the anterior wall of the rectum. Fluid is divided into simple or complex depending on the presence or absence of internal echoes. Here's an example of a simple fluid. Notice the absence of internal echogenic material. In contrast, here's an example of a complex fluid with a large amount of internal echoes or debris. You should always quantify the amount of fluid appreciated as well, but defining exactly what constitutes small versus moderate fluid can be difficult. To simplify things, we use the rule of thirds, meaning that if free fluid extends up to less than a third of the posterior wall of the uterus, it is a small fluid collection. If it extends up between a third and 2/3, it is a moderate, and anything extending above 2/3 of the posterior portion of the uterus is a large collection. The last topic we're going to focus on is sonographic findings, which should raise your suspicion for an ectopic pregnancy. You may occasionally be able to definitively diagnose an ectopic with ultrasound. However, for our purposes with the point-of-care ultrasound, the main goal is to estimate the risk of ectopic, not to identify the ectopic. Remember, just because you cannot identify a definitive ectopic does not mean one does not exist. Here are a list of sonographic signs concerning for the presence of an ectopic pregnancy, going from least concerning to most concerning, and we'll break these down one by one. First of all, the absence of intrauterine fetal parts is very likely the first concerning finding, which will be evident sonographically. However, its sensitivity and specificity for the identification of an ectopic is pretty low. Remember, absence of intrauterine fetal parts will be present in early normal pregnancy and can also be user dependent in less experienced sonographers. The identification of a pseudogestational sac should always increase your concern for an ectopic pregnancy, and careful evaluation of the adnex and both ovaries should be undertaken. As mentioned before, differentiating between a gestational sac and a pseudogestational sac can be very challenging, and this is why specifically for point-of-care ultrasound, we do not rely on identification of a gestational sac in confirming an intrauterine pregnancy. With that said, as you can see in this clip, a pseudogestational sac lies in the midline of the endometrial stripe, differentiating it from the gestational sac, which you would expect to lie just off the midline. You also do not see the double decidual line as you would in a gestational sac. Fluid in the cul-de-sac can be either physiological or pathological. The more fluid that is identified, the higher your suspicion for an ectopic should be. Any complex fluid should also give you pause for concern. Here's an example of a complex fluid. Remember, the key difference between complex fluid and simple fluid is the presence of echogenic material. This echogenic material is what makes the fluid collection complex. Identification of any adnexal mass should be very concerning for an ectopic pregnancy, especially in conjunction with an empty uterus or presence of a pseudogestational sac. In this example, you see the ovary here, and you can see this adnexal mass sitting next to the ovary right here. Here's another example of an adnexal mass. Again, you see the ovary sitting right here, and adjacent to that ovary, you see this adnexal mass, which is an ectopic pregnancy. And one last example, here you have your uterus and long axis, and right here you have an ectopic pregnancy. Identification of an extrauterine fetal pole or yolk sac is an ectopic pregnancy. In this case, you see the ovary, and adjacent to the ovary, you see this mass that has a gestational sac and a yolk sac within it. This is an ectopic pregnancy. The most definitive finding for an ectopic is the presence of an extrauterine fetal heart rate. In this case, you can see this extrauterine structure, and you can see the flickering of the heart rate. Now, this concludes the major topics for the introduction to pelvic ultrasound. I'm going to conclude the lecture with a few pearls of wisdom and discuss common pitfalls associated with the pelvic ultrasound. First, let's talk about heterotopic pregnancy. By definition, it is a non-uterine or ectopic pregnancy along with an identified intrauterine pregnancy. Though we know these do occur, the occurrence is so rare we assume the risk is negligible when performing the point-of-care ultrasound. If the female is on fertility drugs, the occurrence of heterotopic pregnancy increases significantly, and these patients will need a much more detailed evaluation of their adnex and ovaries. With that said, research has still shown the odds of missing an ectopic with transvaginal ultrasound, even on females with an intrauterine pregnancy and on fertility drugs, is extremely rare. Attempting to rule out an ectopic pregnancy based on history and physical alone is extremely risky. In a study, 33% of patients with an ectopic pregnancy had no abdominal tenderness, and 10% of the patients reported no abdominal pain. This goes back to my personal philosophy that I mentioned earlier. If a female who is in early pregnancy who hasn't had a confirmed intrauterine pregnancy on ultrasound presents during my shift with any complaint aside from a stumped toe, they're likely going to receive an ultrasound, as it's a very quick, easy, and highly beneficial study. Now, when performing the ultrasound, if there is no intrauterine pregnancy identified, any adnexa finding other than an ovarian cyst should be considered an ectopic. Let's now take a second to talk about the beta HCG, as this topic consistently comes up when talking about the point-of-care pelvic ultrasound. Now, as you know, the HCG level has been correlated to the appearance of an intrauterine fetus using ultrasound, and long ago this discriminatory zone was developed stating that at an HCG level of roughly 6,000, you should be able to see a normal intrauterine pregnancy by the transabdominal approach, and at a level of about 1,500, you should be able to see an intrauterine pregnancy via the transvaginal approach. Now, the role of the HCG with ultrasound is often misunderstood. I frequently will have a resident come to me and tell me, this patient only has a beta quant of 1,000. Why should I do an ultrasound if I can't even expect to see the fetus? Now, if you go back and look through journals and case reports, you'll see that this notion is not true. There have been numerous case reports of ectopic pregnancies where there's been an undetectable HCG. If you take a look at this study by Doss, he took 47 ectopic pregnancies and looked at what their specific HCG level was during the detection of the ectopic pregnancy. And this surprised me a little bit. In about half of the ectopic pregnancies, the HCG level was less than 1,000. And as you can see, only about 15% of them were above 5,000. Now, if you identify an empty uterus in combination with an HCG level of greater than 1,800, this should be very concerning for an ectopic pregnancy. However, remember that the HCG does not rule in an ectopic pregnancy either. In a study looking at normal pregnancies, 53% of women had an empty uterus at HCG levels of greater than 1,800, and none of them had an ectopic pregnancy. Also remember that an empty uterus with an elevated HCG above that discriminatory zone can be seen in ectopic pregnancies, twin gestations, miscarriages, or molar pregnancies, along with the normal pregnancies. A single measurement of a serum HCG is not only potentially falsely reassuring, but also unhelpful in excluding the presence of an ectopic pregnancy. If you continue to go and look at the research on this topic, you'll start to see a trend that HCGs are not only potentially falsely reassuring, but also unhelpful in excluding the presence of an ectopic pregnancy. A single quantitative HCG is nearly meaningless. Ectopic pregnancies can have any HCG level, and only with serial testing do HCG levels contribute to a diagnosis. Now, moving on to my last point, this is more of a pet peeve than an educational point, but remember, no predictors are absolute. When performing the pelvic ultrasound, caution should be used on any information given to the patient. Unless there is other clinical evidence suggestive of a miscarriage, I would strongly recommend against not making the diagnosis of a miscarriage on a single visit with a single ultrasound. All of those patients should be referred for serial HCG testing and repeat ultrasound with obstetric counseling. It's not an uncommon story to hear of a physician who evaluates a patient, a pregnant female, and does a point-of-care bedside ultrasound and doesn't see what they expect to see, and then diagnoses a miscarriage or tells the patient that their child has died, and cause that female to have a lot of depression and grief just to go on to have a normal pregnancy. Remember, every pregnancy is different, and every fetus will develop differently. So just because you don't see what you would expect to see on your initial ultrasound, it's always safer to have that patient have a repeat ultrasound in 2 days before making a firm diagnosis, which could cause a lot of grief in a patient. To conclude, bedside pelvic ultrasound can have a dramatic effect on clinical practice. The use of point-of-care pelvic ultrasound significantly decreases morbidity and mortality in the first trimester pregnancies. Remember, the primary goal is for the detection of an intrauterine pregnancy, and specific sonographic findings can significantly heighten your concern for an ectopic pregnancy. Thank you for listening.